Okay, Assalamu alaikum. I'm really honored to be here today. I'm standing in front of my senior colleagues, Professor Zakwan, and ladies and gentlemen. I hope a lot of people know me at this stage. I've been in Lahore for almost 3 years now, since I moved back from States. Been working in the Shalimar as an interventional cardiologist. Today we are talking, it's kind of a little funny that interventional cardiologists usually talk about the high-fi kind of procedure and all those kind of things, and today we're talking about hypertension. You might have read on my resume, I have something called MPH, and I'm really proud of that. That kind of gives me all the time enough courage to come and talk about the preventive cardiology and preventive medicine. And I think this is very, very important, especially the way we are going through in this healthcare system. Okay, without any further delay, what we're going to do here, I try to be very casual. If you have any comments, suggestions during the talk, please raise your hand. I will stop. But I understand they want you to have your comments and questions at the end when the consultant seniors will be sitting on the podium. So you can hold for the end, but in the meantime, in the middle, if you have something, please go ahead. I really say the hypertension, worsening healthcare issue is part of all the advances in the pharmacology, pharmaceutical industry. Since we're in the medical school, we have been seeing number of the drugs. By the way, I was not here in the medical school. I'm talking about here myself. Okay, but we're talking about here. Look at the drugs have been advanced with the various different chemicals, pharmaceutical industry progression, advances in the pharmaceutical industry to treat the hypertension. But where we stand today, instead of all that, the things are not good. They're not promising. World Health saying, we still have nowadays 1.3 billion. बहुत बड़ा number. 1.3 billion people in the world having hypertension, and then 4 million, 40 lakh बंदे हर साल direct effect of the population से उनकी death हो जाती है. This is a big number, big healthcare trouble. So everybody knows these slides. In terms of the risk factors causing the deaths, hypertension remains on the top, and look at the number, way higher compared to anything else. We're talking a lot nowadays about this dengue and the COVID and all those things, but I think the world is forgetting this hypertension issue, and we should not. Now there's another funny slide here. If you are poor, which we are, if we belong to a poor country, and if you have hypertension, we have more risk of dying from the virus. Now, I don't know why. So, it's kind of funny statistics. And probably the reason is that the rich people, the advanced countries, they have done a lot to control the population, which we'll see where the variety is. But being in Pakistan, we call in the low-income countries, our risk of having a death from the heart potential is way high. Okay, this is data going back, I think, in the early 2000s by the National Health Survey Pakistan and Pakistan Hypertension League. They have said 1 in 3 people over the age of 45, 1 in 3 of us sitting in the room over the age of 45, we have a hypertension, whether it's known or not. That's a big question. So it's a big number. Look at the country population and look at the number we're talking about. And I can put a slide here. We also doing some project in Lahore. And we're seeing it's very much true. We have preliminary data and it's very much true, and maybe even more in certain pockets of the law. Okay. This is somewhat disturbing to me. 50% of those diagnosed were ever treated. This is according to their data. And only 25% of patients were adequately controlled. So, is a problem, a big problem. And this is our country's data. So, what situation, where it came from? Situation is not good over there either. Okay? So rich country, big resources, but still 1 into 3 adult population in the US just have a hypertension. So they are running in the same situation as we are. I think their control is a little bit better than us, and they know it's not a one-day job. It takes years and years to control it. So they have made a reasonable target by 2025 to have a 68% control of people. That's their target. Do we have anything in this country? Probably not. We are way behind for any 5 or 10 years healthcare plan. That's the same thing in the graphics. I'm just omitting that. So, uncontrolled hypertension is bad. I don't need to tell anybody. You guys already know that. We know from medical school onward. It caused all these damn problems, starting with heart attack, heart failure, LVH, stroke, dementia, you name it. Okay, and we all know that uncontrolled hypertension, it has a 3-fold increase of heart failure, which we deal on our end, and an 8-fold increase of stroke, which my neurologist fully deal with that. Big problem in this country, in this society. And not only this society, we have across the world. Okay, I am putting in 2 questions here. Confused scenario, and they're the real patients. They're my patients, they come to see me in the clinic the last couple of days. I thought, why not share with you guys? And we will have the answer at the end. Statistics of female, journalist fatigue, intermittent headache, dyspnea, exertion, no medical history except hypertension for years. Hello? 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 Okay, good. So that's the medication. Her labs are normal, kidneys are normal. Somebody's treating her with a lipitor, aspirin, Cordavan. My understanding, I learned which are expensive medicine, which are less, so probably not expensive medicine. She is on. And what is the next step in her management? Because this is her profession. And every patient with hypertension, I don't see them in the clinic on the follow if they don't bring the diary. So she brought the diary and the blood pressure like a 155 to 170, that's the range of the blood pressure. And she is religiously taking her blood pressure medication. She says she takes the blood pressure medicine. Okay, so what are the options we have here? We will come back at the end of the talk. Another gentleman, 61-year-old, who's had a history of coronary disease, stands for 2 years ago, hypertension, diabetes, typical patient we see every day. And these are his medications, and now the blood pressure is this. What are we going to do? What is the further action? Increase the dose, increase AR, chloroquine, or we start some chemotherapy. We need to control the blood pressure. That is the whole game. And we'll come back at the end, which are the preferable our actions. Now, this is a major problem, I think. This is me who's saying that this is a major problem. What it means that hypertension definition. Okay, you name. Do you guys know how many societies in the world have been dealing with the? I only today learned there's an Indian society of hypertension as well. Okay, we have Pakistan hypertension, and believe me, most of them they have their own definitions, and those definitions changes every 2 years or sometimes 3 years. And then in one country they have a GMC, that's America, and then AHA, ACC, and American Society of Hypertension too. I don't know what's going on. I think there are too many chefs in the kitchen, and I think nobody's understanding what is exactly the reality and what should be treated. Everybody coming up with the different aims, different definitions, and making people confused. At least me, I get confused with this. So, who should we believe or not? I think blood pressure greater than 140 over 90 in an otherwise normal person is called hypertension. That's what I think. And that's what and why we say that? I can tell you something here. I'm sure you all read the cardiovascular, the neurology related trials, the diabetic related trial studies. Have you ever seen in those studies what was their major, when they control the patient, when they try one drug to the other ones, they always want to have the good result of their arm, and they keep the blood pressure under these readings. Okay? So, if we have all the scientific data, hundreds and thousands of the studies, which are done not for hypertension, for other purposes, and if they have a target of this, then why do we have so many different numbers? I don't understand. Obviously, there are a lot of genius people in those meetings, those committees, and those who come up with the guidelines. So there must be some reason, but it's at least making us confused. Now, some of the facts in terms of the management of the hypertension. I want you to understand this. Control remains poor. We know that. Whether in Pakistan, whether in states, whether in the world, it's bad. Now, the interesting thing is, one drug controls blood pressure on only a quarter of the patient. That's it. And most of the patient, I'm sure you guys have your observation, your own personal experience in the clinics. Most of the patient requires more than one drug, whether 2 drug, 3 drug, 4 drug, we don't know. and to control their blood pressure. Okay, the important thing is that we know reduction of the blood pressure, irrespective of type of medicine, is benefits in all the drugs. So we need to control the blood pressure, and we need to have this concept in our mind. The one drug is okay to control blood pressure in only quarter of the patients. Most of the patients are going to have either 2, 3, 4, or even more drugs, and you guys witness this every day in your practical life. Okay, I put these slides up because I feel this is a somewhat practical definition of the hypertension in terms of management. I was part of this subcommittee of the JMC7 guidelines, and what happened? They have come up with this after a big trial. You guys all know that all had trial, and this is a definition which a lot of people did not buy a couple of years ago, but now the others are thinking that this is very reasonable in terms of the clinical management of the patient. So, elevated blood pressure. This is a number. You should not ignore your patient. Okay? Stage 1. And some others are saying it's instead of stage, they are using the other word, the grade. Some of the International Society of Hypertension now, they have using the grade word. But this came up originally after the GNC7 all had trial. So if your blood pressure stand here, it's a stage 1, it's a high blood pressure, and this is stage 2, when it's a very high blood pressure. And of course, you guys know the hypertension crisis. I hope up to here things are okay. I hope I'm not confusing you guys. And that's why I didn't put all these various societies or various definitions. I skipped that part. Because I know the more we see, the more we read about the societies, we're going to get confused. We want to be very practical and on the point. So I want you to remember this. I'm sure you already know that. Okay? So what happened? This originally came up in 2003, 4, 5 originally, and a lot of society didn't buy it. And eventually, light is a problem, guys. Folks in the back, I'm sure you hear me? Okay. So what happened over the years, over the more and more data came up, and then 2017, the number of the societies, look at the number, the names, 1, 2, 3, 4, 5, 6, different societies, they came up and they said, well, I think this is a reasonable and the definition of the hypertension in terms of the management. So we're standing back to the circle there now. This was originally in the 2003 or 4. Okay, so I personally use this one, and I really beg you guys to follow this plan. It will help you in terms of patient management. Okay, I said this International Hypertension. This is, I'm just putting it in one slide to show you how much they got confusion about this one. You read all those 1 step, 2 step, 3 step, at the end you don't know what we're talking about. The good thing is that in 2020, they have adopted the same thing which we just said, this one. Okay? So they have come up with the same, except that the name changed with the grade 1 and grade 2, but they have accepted the same kind of a definition eventually. So, moving forward, we have gone through the background and the definition and what is the practical kind of the definition is, what we're going to do. We know all these things are available. All things are available. The only thing I put this slide is I want you to remember this. Each increase in the blood pressure, 20/10, double the risk of the cardiovascular disease. So we have to be very careful. We have to be on the spot. And need to control the pressure aggressively. Number of the medicines available. I'm just going to skip that. You guys all know that. The blood pressure treatment strategy. It has been changing over the years with all this background. And I think because people have never come up with one strategy, that's probably the reason we still have so much uncontrolled hypertension in the world, because this is probably one of the reasons along with many others. So, up to 99, the guideline that just started one medication and then gradually increased the second, third, fourth of it, that was considered the best strategy. Over the years, things have changed, and that I said, after all had trial and the JNC7 guidelines, people got to know that the monotherapy is only effective 25% of the patient, and most of the patients require more than one drug. So they thought we need to do something. So we need to start with the better ideas of the blood pressure treatment strategy. And that's happening somewhat in the world now. This was a major trial, with the two drugs, which led to all this belief on the people that we need to do something in terms of the combination. So one major first trial, somebody asked you what the accomplished trial, there's a 40,000 patient drug trial. I'm not going to detail that. It showed much better control with this one and this combination compared with other usual care. Then, what happens now? As I said, the things that change further, and eventually ACC and HA and the European, they start talking about the same thing. We need to start, first they said one therapy, then they said add-on, they said the combination. Now they're talking about something additional. They're saying if you, because the data is coming more and more, so they're saying if you have a patient in your clinic, in your hospital, who is having a blood pressure like this, stage 2 blood pressure or grade 2 blood pressure, according to ISH 2020 guidelines, you ought to start with the two agents. So things are changed. People learn. We learned over the years. And this was something good. Because we knew that more than 80% needed more than 100 anyway, and whoever is presenting with the grade 2 should be starting. Obviously, there will be lifestyle modification, all those things. That is there, but we're talking about the drug treatment. And so I'm just going to show you the way that people come up with this, 2 drugs, 3 drugs, stepwise. Yes, these are all there. Every society has their own pages, and some of them like simple here, some too much complex. And another slide to show you how complex the situation becomes when people make these recommendations to you. You don't know whether you're white, whether you're black, whether you're a brown person, and things are different for each everybody. This is something probably there, but I think we need to move towards the reality. The reality here, when you have to start with the 2 drugs, and if needed, you even need to thinking about a 3rd drug as well. Okay? 80+% of the patient needing more than 1 drug, and of some of those, which we know next now, how many of them need more than 2, we have to look for those patients. So that we can start those patients, we can target those patients for aggressive blood pressure control. This is an important message. I think we got this message way back. If we delay blood pressure control in patients with type 2 diabetes, which is prevalent in Pakistan, my understanding is it's 1 in 5% or 1 to 3%. I don't know how many people in the whole have a type 2 diabetes. Too many, right? So if we delay the blood pressure control treatment, what happens? This is the life expectancy, this is during the month. So you lose these many number of days, these are the days you lose in terms of your life expectancy as well as your quality of life. If you delay treatment for 5 months, 10 months, 15 months. Same way, if you delay treatment in those patients, these are the complications, amputation, heart failure, and renal disease, these occur. So suppose if there's a patient you have in your clinic, and if you delay his or her treatment to optimal control for 10 months, for a year, you have at least, look at the way you're standing here, double the risk of having all these complications. This is a big message in terms of the need to have an aggressive blood pressure control. Then, it's a big data, 90,000 hypertensive patients followed up in UK, in the general practice, and they found the 2 features in those patients who were getting the delayed hypertension, whose blood pressure were not controlled well. In those patients, the systolic blood pressure of greater than 150, if that was there, or if there was a 1.4 month of delayed treatment in that group, you're going to have a lot more deaths in that group. So again, the message is, if your patient has a hypertension, it needs to be controlled. That is our message. Now, we move from 1 drug, additional 2nd, 3rd, 4th, 99, 2001, 2002, 2003. Combination drug concept came up, 2004 onward. People started using 2 drugs, and still they know that the blood pressure is not being controlled optimally. So people start coming up with ideas, and they start having trials before actually giving the market some strategy. So this is David Callahan came up with this idea, putting in a 3 drug combination in a large first trial. And this was done in the late 2000s. And they showed us that this is what they showed us. the reduction in the systolic blood pressure and the diastolic and I think the mean diastolic and the mean systolic pressure within weeks. And that's what you need. That's what you need. You need to treat those patients aggressively. They have a different combination came up in that. I'm not going to detail, talk a little bit at the end. So that was the idea, starting having more than 2 drugs to start with in the people whose blood pressure is not adequately controlled, either with 1 drug starting and adding a second, or started with the 2 drug to begin with. So they were able to control the blood pressure pretty aggressively. And then, what was happening then? The one thing was coming up. Obviously, if you're using a higher dose of a medicine, whether in combination or alone, you're going to have even more side effects. No brainer, right? Simple thing. So what was people were saying, why don't we go ahead and instead of going on a 2 drugs with a higher dose or 3 drugs with a higher dose, why don't we start with a 3 drug in a low and a moderate dose combination and start those patients on the in the trials. So this was one of the large trial. The Trump group study came up a couple of years ago, and they showed when you use the drug in a lower fixed dose, and I will tell you the lower fixed dose in the valsartan is 80 milligrams, the immunoglobulin 5 milligrams, and the hydrochlorothiazide 12.5 milligrams. That is considered the low dose in this combination. Okay, and they came up with this. By the way, did you ever think about why people use this combination, even the dual or triple? The combinations are Asad with the diuretics and Asad with the amlodipine, or the triple is ACE or R with the amlodipine and the diuretic. Has anybody think about where this data comes from? All had trial. All had trial. Where all these drugs were tested, and they were done individually, and all of them have showed the blood pressure very effectively controlled in that made it was 46,000 patients in that trial. 36,000 patients, and they showed these drugs were very, very effective blood pressure control. And then people started coming up with the combination. So they are well-tested drugs in terms of the blood pressure control, and that's what the people are playing with. So different combinations showed the good control, and then the low blood pressure control showed very good control as compared to the usual care, but with a lot less side effect. Lot less side effect. The only thing I want, if I'm going to take the ACE inhibitor, I don't want to have my kidney function get deteriorated over a period of time. That's my concern will be all the time. So I would prefer a lower dose with another medicine rather than having a full dose and more side effect. And I'm sure you all know that when we started drug, the first dose drug blood pressure decrease is never get double or quadruple by doubling or quadrupling the dose. Suppose you're starting a drug, say valsartan on 80 milligrams, suppose, and you're reducing blood pressure 10 milligrams. If you're increasing it to double 160, it is not going to reduce your systolic pressure of 20 milligrams. Okay? But it will increase your likelihood of having a side effect high with a high dose. So low dose, the medium dose with combination probably play better. Okay. Oh yes, that's the side effect. Increasing the dose of the amlodipine in that study, and we keep seeing the major what you call the edema in those patients, and we see all the time. Okay. The moment it goes more than 5, all of my patients start having edema. And the combination, even that edema requires, I just showed you one of them. So again, now people have changed. All societies have started changing their ideas, their definition, their strategies. Now they're coming up with this. Initially they were saying mono drug, now they're saying combination drug, and they're saying now a combination, they want it, that's their goal, and the combination, if that's for the goal as well. That's what the International Center for Hypertension 2020. Obviously the combination will depend on your patient's actual blood pressure and the other diseases, comorbidities. Another couple of slides left. Another big trial published a couple of years ago where we showed that the blood pressure in a number of thousands of patients, you see the combination with this valsartan, amlodipine, and hydrochlorothiazide, it reduces the blood pressure pretty quickly within weeks, and that has been shown by Calhoun and the group in 2009. We know that. This showed it very successfully. I think this is important to me. of all this data, this is the most important for me. They showing that in the same study, they showed that 77% of patients achieved optimum blood pressure control with the combination. I know when they do the trial, it's an ideal situation, but it's real, and we know the otherwise the usual routine care or treatment of blood pressure, optimum control is less than 1/3. We know that part. So I think this is promising when we treat the patient with a combination of the three. Is all the question comes up, what doses we're going to use that? Are we going to use the higher doses, or are we going to use the low doses? And I think that depends on your individual patient. And you have to individualize the treatment. One thing won't fit for all. You have to see what the patient's blood pressure, what is the blood pressure over years, what are the comorbidities, and depending on that, you will fix your, you will pick your combination. Now, going back to the my first question, the 56-year-old female, as I said, she was coming up here in spite of taking all these medicines, and her blood pressure is still up. It's 150 to 170. That's what I'm at home, and I have options: change RP, add ACE inhibitor, add hydrochlorothiazide. In addition to this, and separately add beta blockers, or you simply start low triple therapy with the lower medium doses. So I picked up in this patient myself. I think with all this data and all this history, I would go for this in this patient. And my next patient, where my blood pressure target is even lower because the patient history has CAD, hypertension, diabetes, and the history goes low. Oh, sorry, the target are even lower, and the blood pressure is poorly controlled. No further action, just a lifestyle modification, and the increase the dose of Mirol. I can't do that. The heart rate is less than 70, and the increase the dose of the ARB in the combination. I said earlier, doubling the dose will have a little effect on the blood pressure control. It may double dose side effect profile. So again, the European dose, I personally don't use the 5. It's a lot of edema, other side effect comes up as with any other drug. So I think this patient will do good with the triple therapy as well. With that, I think I'm going to conclude here. The hypertension, we all know that. Okay? Effective pharmacological treatments available. The issue is that how to use those tools. We have, I showed you a slide from 1950 to 2000. We have a number of the new drugs came up in the market. All of them have shown to be proven reducing the systolic and diastolic blood pressure and reducing the morbidities, comorbidities, mortality. But the art is how we're going to use those. Problem is, in addition to that one, the underdiagnosed and inadequate treatment. So that's what I'm talking about, the art of treating those patients. I said many times in the talk, 80+% need more than one drug, and a quarter to 30% need 3 or more. For the sake of time, I didn't put another slide. Somebody actually in the late 90s to early 2000s in the UK, they did a very good research. There was only 1,400 patients in that trial, but they did a marvelous job. They had a male and female from the age of 18 onward adult, and they actually monitored those patients for 5 years. How many? Because in those days, the idea was only to pick one drug and add in addition if you needed. So in that study, what happened? They find how many people were needing 3, 4, 5 drugs, and interestingly, more women. Only 12% of the women were having a control operation with 2 drugs. Most of the women in that short cohort needed 3 or more drugs. And in the male, a little bit lesser number, but still not more than 1/3. So keep in mind this 1/3 number. Your 1/3 patient in your clinic, in your hospital, are going to be needing 3 drugs to control the blood pressure. That is the message. And you have to pick up those doses, initiating the combination and starting how we go. And keep in mind, delaying those slides where I showed you that delaying the blood pressure control, even in the months, 2 months, 3 months, how badly it's going to affect your patients. So those things should be in your mind when you treat your patients. Oh yes, one more thing, compliance. If I have to take a medicine, 3 drugs a day, and then the morning and evening dark, it's not possible for me. I hardly finish a course of antibiotics, believe me. So how to take a 2 or 3 drugs in a day? I think the combination makes it simple. I know it's easily said, but it's going to make it simple. Yes, it's shown now, the combination therapy, we have well over 15, 18 years now, the people have been using the combination, and in the real world, things are getting better. Some of the studies actually enroll Indian people as well, some of the studies. None of them are from the Europe and the America and the South America, but some did enroll Indian people, and they did tolerate very well, and it worked great in those. Unfortunately, I didn't find any study where it worked actually Pakistani people, but I know with an Indian population. Problem. Okay, the combination of amlodipine, valsartan, and hydrochlorothiazide, which we are here today with this Asad Plus, provides blood pressure reduction and consistent control of patients that are not controlled on the dual therapy. Okay, so this is a message I'm delivering. I intentionally did not pick a dose for you guys. I am not watching for a particular dose. I'm not saying start with the 160 of valsartan, but the 25 of hydrochlorothiazide and a 10 of amlodipine. I think it is on you have to decide. It's up to you. You will decide which patient will be needing low dose and which patient will be needing high dose. Obviously, you know your patient, and after a couple of visits, you will decide about the doses. But definitely, it seems to be working, and 1/3 of the patient will be needing this drug, this combination. I think I'm going to stop here, and thank you very much. I hope you guys won't ask any question for me. We have a secret folks sitting on the front of the podium. And I was trying to run away from that, but I will. I know I won't be able to do that, but yes, I will. So, I will certainly have some comments on it.
Professor Javed, Ashraf, excellent presentation. Or obviously you are updated with the recent trials and guidelines, and obviously hypertension, I could say that it's a problem for each and every person now, and in the families this hypertension is running like anything, and the major problem in that it has no symptom. This is the main thing, and we must have to educate our people, patients, that it's usually when it starts producing the symptom, it means something is going really bad in the body. So this must be kept in mind, like diabetes. So hypertension is obviously not mostly causing the symptoms, so that's why it's already there, and patients come for the diagnosis, and you already told that they are underdiagnosed because of this issue. And the second thing is that the people, they have their myths. Even if they are taking the medicines, they say, Doctor Sahab, मैं तो दवाई तो खा रहे हैं, और blood pressure कितना है, 150, 160 systolic चल रहा है. The point is, we have to tell them, even if you see the guidelines, we have seen that even systolic 115 and diastolic 75, from here, if the blood pressure increased by 20 by 10, systolic and diastolic, the risk becomes double. Even at 135 systolic, the risk becomes double. The guidelines are there are studies, the risk for the cardiovascular, the stroke, the other problems are already there. So this is a major issue that we must be addressing. We must be educating our people that don't take it lightly. We must be taking seriously, because as you have already told, there are so many problems which can occur because of this, and the life expectancy, we are already having life expectancy much less than the other countries. I think around 67 now, 65, 67 now as compared to the others. So there are so many factors. The one factor, one thing which is the hypertension, which can be easily treated, which can be easily managed, I think we must be addressing our people that we must take care of this thing. So thank you very much, Dr. Javed, for really excellent presentation, and thanks to Pharmacological. And we are here for the questions if there are any. Dr.
One question from Sir. Sir, we are going to manage hypertension. Why we add the alprazolam and is angiolytic? When we are going to destabilize the mental then how we are going to expect that this patient would be treated by the antihypertensive drugs rather than by the anxiolytics?
I think it's a great question. I hope people in the back understood the better. Sir, question here, when we treat hypertension, why do we add anxiolytics or other drugs to treat? Sir, I did not mention any of these drugs in my slides, and I don't treat hypertension. No, that was not a part of the hypertension treatment. Those were the patient's medications at home. I never used an anxiolytic as a treatment for the hypertension.
सर इसमें अगर मैं थोड़ा सा ऐड करूं थोड़ा सा इसमें अगर मैं हाँ श्योर
One patient was taking alprazolam, another was exactly, but that was not a part of their treatment. I think that's most of the people are using anyway. I personally don't consider these are antihypertensive, and I never use them as antihypertensive myself. Sir?
जी सर विद रिस्पेक्ट सर मेरे सीनियर भी हैं डॉक्टर अशरफ भट्टी साहब और विद रिस्पेक्ट सर द पॉइंट इज के जो पेशेंट्स हाइपरटेंसिव हैं उसमें ऑब्वियसली वन ऑफ द फैक्टर इज स्ट्रेस इसमें है लेकिन आई थिंक दिस इज माय पर्सनल ओपिनियन में भी कि जो गुड वर्ड्स हैं किसी भी क्लिनिशियन के टू द पेशेंट और उसकी बात को सुनना और उसको टाइम देना आई थिंक इट एक्ट्स एज समथिंग लाइक एंग्जाइटी So I think we should not be considering anxiolytic as a first-line drug for as an antihypertensive. So I think this is the main thing, and then obviously considering the antihypertensive medications, depending upon the blood pressure values, we must be starting the medication. This is the main thing. So our words must act like anxiolytics.
It is a matter of a multifactorial practice. Physician.
Yes.
But when the cardiologists add up this hydrochlorothiazide, but they are not sure, and moreover they add the beta blockers to asthmatic patients and diabetic patients who are already intravascularly depleted due to asthma and due to diabetes, and now empagliflozin, which are also acting as a diuretic. How we are going to add the hydrochlorothiazide to these patients?
Okay, again, a wonderful question. First of all, I must say that being a cardiologist, I think we are not the best people to manage hypertension. Is that right? I hope you agree with me. You say yes, man. The best people are you guys. The general practitioner, the internist, you guys are the best people to manage hypertension. I consider myself a very specified. Yes, we see a lot of patients with hypertension. And yes, the second part of your talk, the people who are in the medical field, among the medical field, the internists, the family physicians, and general practitioners, they know their patient very well, they know their circumstances, they know them, they see those patients routinely. I think they are the best people. Coming back to your question of, I give you most of the patients I'm going to see as a cardiologist, they are going to have an underlying either heart failure or coronary disease. So we are up to have a treatment with the beta blocker, a must treatment unless they don't tolerate it, because we know the benefit of that treatment is way, way high. So that's why they are in our treatment. Number two, and by the way, the beta blockers are not considered as an antihypertensive in any of the recent guidelines. They used to, but not anymore. So that was the one reason we used it. Regarding your hydrochlorothiazide question, well, I hope most of the people in the room, or all of them, I'm sure you know that, the mechanism of hydrochlorothiazide using a 12.5 milligram to control the blood pressure is not as a diuretic. I usually tell the people to take a 25 milligram hydrochlorothiazide and see how much you pee the next 24 hours. So blood pressure and the effect of that with the chlorothalidone, which was used in the original trials, or the drug, the other drug hydrochlorothiazide, that is an arterial vasodilatory effect also. So most of the patients जो हम hydrochlorothiazide 12.5 में use करते हैं, उसके ऊपर the diuretic effect is not a major effect on those patients. It is used as an antihypertensive because of the vasodilation. I hope we answered your question to some extent.
your question. No, I think Dr. Javed Ashraf gave an excellent talk and Professor Saab summarized everything. We should emphasize one thing that, as he said, this is a silent killer. You don't get symptoms from hypertension unless and until you have an accelerated hypertension, which is a specific diagnosis and it's a different treatment. Number two, we have to emphasize to our patients कि जो हम दवाइयाँ उनको दे रहे हैं मेंटेनेंस है, ये क्योर नहीं है इस बीमारी का. So जो hypertension है ये क्योंकि आपसे मरीज आएगा 60 साल में रहेगा ये सारी जिंदगी में दवाइयाँ आएंगी. So you have to emphasize the fact that this is a maintenance thing. ये नहीं कि आपने एक माह दवाई खा के छोड़ देनी है. That's very important. और बाकी ट्रीटमेंट जैसे डॉक्टर साहब ने कहा वो मुख्तलिफ कोई भी गाइडलाइंस फॉलो कर रहे हैं. I think most of the patients have diabetes or chronic kidney disease or cerebral vascular disease or ischemic heart disease. So the goal is 130 by 80. Those patients, rest all the population 140 by 90. Just remember that. And if you see somebody with a systolic of 160 and a diastolic of 100, just put them on a combination therapy. That's pretty much it.
और भी पूछ सकते हैं?
जी सर जरूर पूछें.
Sir, before the winter, one patient is well maintained on certain drugs, but at the entry of the winter, his blood pressure is shooting.
जी.
So, should we, moreover, if he is taking cold water, his blood pressure is again shooting. So, should we manage this transient rise in blood pressure?
लेकिन ये उसमें इस तरह आ जाता है कि उसका पानी पीने से कोई ताल्लुक नहीं है, ना पानी से उसका ताल्लुक है, ना अदरक से उसका ताल्लुक है, ना उसका 7-अप पीने से ताल्लुक है ब्लड प्रेशर की मैनेजमेंट का, ना उसका ज़ेनेक्स और एल्प्राज़ोलैम से ताल्लुक है. अगर आपका ब्लड प्रेशर हाई है तो उसका मोस्टली ताल्लुक आपकी खुराक से है, आपकी एक्टिविटी लेवल से है और आपका जो बार वेदर है उससे है. We live in a hot, गर्म weather. This is a warm, Pakistan, at least Lahore, Punjab is a warm place. So most of us sweat during the summers. That part is essentially eliminated. In winters, our water intake is much less than summers. ठीक है ना? ये दो चीज़ें. नंबर 3, I'm pretty sure आप सबको एक शादी का इन्विटेशन है रात को और जुम्मे हफ्ते इतवार को 3 कार्ड होंगे हर एक के घर में. ठीक है, खुराक बदल जाती है. बाहर यखनी उबले हुए अंडे वाले लोग फिर रहे होते हैं पार्कों में बेचने के लिए. मछली बहुत खाई जाती है यहाँ पे कॉमनली जिसके अंदर बहुत सारी. सो इट हैज़ गॉट नथिंग टू डू उस तरह का. ये सिक्लिकल इवेंट आता है और ये मुख्तलिफ सोसाइटीज़ में देखा जाता है. हमारी सोसाइटी में इसलिए प्रोनाउंस है कि हम एक गर्म इलाके से, हमारा गर्म खत्ते से ये ताल्लुक है. जो टेम्परेट एनवायरनमेंट से वहाँ पे ये चीज़ें जाती हैं, स्विंग्स नहीं होते, वो लोग इतना नहीं देखते. बट दिस इज़ अ वेरी, यही पेशेंट्स फिर आपके पास मई में आएंगे, जून में जब उनका बीपी लो हो जाएगा. तो कुछ डॉक्टरों का भी काम चल रहा है, कुछ फार्मिगो का भी काम चल रहा है, तो ये थोड़ा बहुत चलेगा. बट दिस इज मोस्टली रिलेटेड दीज फैक्टर्स दैट आई हैव डिस्क्राइब्ड.
Thank you. I would like to ask Professor Javed his suggestions, comments, and his personal experience on the management of this major issue.
Thank you very much. Hypertension is a major cause of stroke, and it is not confined to intracerebral hemorrhage or subarachnoid. Even ischemic stroke, most of its contributory factor is hypertension. And unfortunately, this is the most ignored area by the patient and even by the doctors. Now, how many people of you take proper blood pressure, and how many you know how to take blood pressure? So I think we should do a study. Very certain. Everybody, coat, jacket, take the blood pressure. Is this not the reality? Now, if you go to the study, they care about 1 millimeter rise in blood pressure. I give you one example. There is a study. They say 2 millimeter rise in blood pressure, systolic blood pressure, increases the risk of 10% in stroke mortality. Now they are watching, and our nurses, they take blood pressure, they raise the cuff up to 200, and then within a second it comes to 180, 140. So whenever patient comes to me and I take blood pressure, my blood pressure is always high. So this is most important thing is we should realize. And second factor is that when patient comes to the doctor, there is element of white coat hypertension. Now the people, they have establish the protocols. If the patient is coming with constantly, sometimes I see patient blood pressure of 200. I said, okay, you lie down. I take other things, history, write down, and then repeat the blood pressure. It is significantly low. So we should eliminate the element of wild hypertension before it is therapy. So I think first thing is that we should realize the patient that the blood pressure, they should take medicine. अब people say मैं सारी उम्र ही दवाई खाऊंगा, मैं उनसे एक ही सवाल करता हूँ, सारी उम्र खाना नहीं खाया, खाना क्यों खाते हो? खाना इसलिए कहते हैं ना, जिंदा रहना है, चलना फिरना है, तो ये भी आपकी ज़िंदगी बचाने के लिए है. सो यू हैव टू कन्विंस दैम. नंबर 2, ब्लड प्रेशर हमारी साइड पे प्रॉपर होना चाहिए, क्योंकि आई सी पेशेंट जिनको कोई दवाई नहीं होती, दे कंसल्टिंग डॉक्टर, उनका भी तरह नॉर्मल है, दे लैंड विद हाइपर इंट्रासेरेब्रल ब्लीड, दे लैंड विद स्ट्रोक. तो आई थिंक सेकंड मैसेज जो मैं आज आपको कहूँगा कि ब्लड प्रेशर को केयरफुली खुद लें. मैं बिजी बहुत होता हूँ, लेकिन ब्लड प्रेशर में हर मरीज का खुद लेता हूँ. तीसरी बात जो इन्होंने की, कम्बिनेशन थेरेपी, दैट इज़ वेरी इंपॉर्टेंट. अभी एक स्टडी हुई है जिसमें उन्होंने 1-2-3 दवाइयाँ अलग अलग दी हैं. ये जो ऑगमेंटेशन का क्या मतलब है? ऑगमेंटेशन 2 अप्रोचेज हैं. एक तो आप जो ऑलरेडी दवाई ले रहे हैं उसकी डोज डबल कर दें, मैक्सिमाइज, उसे मैक्सिमाइजिंग कर दो. दूसरी अप्रोच ये है कि मैक्सिमाइज ना करें, छोटी छोटी डोज कम्बिनेशन थेरेपी दे. अब अगर आप इंडिविजुअली देखते हैं तो कंप्लायंस जो है 50% है. 1 साल के अंदर 12 महीने बाद उन मरीजों की वो एक दवाई ले लेंगे, दूसरी छोड़ देंगे. लेकिन कम्बिनेशन का एडवांटेज ये लेनी तो एक ही होती है. तो आई थिंक दिस इज द राइट अप्रोच कि आप कम्बिनेशन थेरेपी दें और ट्राई कम्बिनेशन बजाय एक दवाई को. मैं ज़्यादा फेवर नहीं करता मैक्सिमाइजिंग द डोज. आई फील बेटर रिजल्ट एंड बेटर कंट्रोल विद कम्बिनेशन थेरेपी. तो मेरा यही है कि एक ही स्लोगन है, स्ट्रोक इज प्रिवेंटेबल, एंड दी ओनली थिंग, अगर आप सिर्फ ब्लड प्रेशर कंट्रोल कर लेंगे. तीसरी चीज़ जो मैं सबसे ज़्यादा दवाइयों से ज़्यादा जोर देता हूँ, मैं उनसे पूछता हूँ सब्जियाँ फल कितने खाते हो, वॉक कितने खाते हो. आज तक मुझे कोई बंदा ऐसा नहीं मिला जो वो कहते हैं जी सलाद खाते हैं सब तो जी पेट खराब हो जाता है, वो चबाई नहीं जाती. तो ये हार्ड फैक्ट्स हैं, तो इनको आप इन करें, खुद भी करें. मैं आप इस ऑडियंस में पूछूं कितने लोग हैं जिन्होंने आज सुबह वॉक की है, कितने लोग हैं जो रेगुलरली 3 या 4 टाइम, जो इंटरनेशनल हेल्दी लाइफस्टाइल गाइडलाइन है, दे से टेक 5 अलाउंसेज ऑफ फ्रूट्स एंड वेजिटेबल एवरी डे. एंड इन अमेरिका उन्होंने स्टडी की थी, रिस्क ऑफ स्ट्रोक एंड हार्ट डिजीज वॉज रिड्यूस बाय 30% विद इन 4 ईयर. ये नेशनल कैंपेन. तो मेरा आपको मैसेज यही है, सिंपल चीज़. नंबर 1, आप खुद ब्लड प्रेशर लें और उनको अगर ज़्यादा है उसको कंट्रोल करें. दूसरा वॉक. तीसरा डाइट एंड देन फार्माकोलॉजिकल थेरेपी. स्टार्टिंग विद वन एजेंट नहीं कंट्रोल होता, कम्बिनेशन ड्रग ज़्यादा प्रेफर दवा इंडिविजुअल ट्रीटमेंट के. तो दैट इज़ माई मैसेज. एंड इफ एनी क्वेश्चन, क्योंकि स्ट्रोक के जो डिज़ास्टर मैं देखता हूँ ना, ये रिवर्सिबल नहीं है.
guidelines to label a person with hypertension.
जी,
Are there any latest guidelines to?
वो मैं आपको बता दूँ, अब 21 की आई है गाइडलाइन. उसमें ब्लड प्रेशर नॉर्मल इज 128. 128 से 129 इज एलिवेटेड ब्लड प्रेशर, बट यू नीड ओनली डाइटरी एंड नॉन फार्माकोलॉजिकल थेरेपी. एंड स्टेज 1 स्टार्टिंग फ्रॉम 130 to 139 एंड लो रेट 29. सो 2021 जो गाइडलाइन अभी वो अर्ली स्टेज पे अभी लोगों ने ऑप्ट नहीं किया, लेकिन यूरोपियन एंड WHO गाइडलाइन जो अभी भी अवेलेबल है वो 140-90 पे अभी टिकी हुई है. तो इसलिए जो आपका सवाल है ना, वो अभी रिसेंटली पेपर आया है और उसके अंदर स्टेज 1 हाइपरटेंशन इज 120 to 129 एंड स्टेज 2 इज 130 to 130. जी
एक तो ये डायग्नोसिस की भी टारगेट है कि कितनी रीडिंग के ऊपर है जो हाइपरटेंशन.
जी जी.
एक होता है कि ट्रीटमेंट किस पे रखना है पेशेंट को.
अच्छा, उसमें भी ये कि ड्रग ऑफ चॉइस जो है 2 चीज़ों पे है कि उसके एसोसिएटेड रिस्क फैक्टर्स क्या हैं. जैसे अगर एक पेशेंट को उसकी एज है, अब जैसे कि एग्जांपल देता हूँ, कोई ज़्यादा रिस्क फैक्टर नहीं है लेकिन एल्डरली पेशेंट है, उसमें जो और आइसोलेटेड सिस्टोलिक हाइपरटेंशन है, तो ड्रग ऑफ चॉइस डायबिटिक्स या कम्बिनेशन ऑफ ARBs इनहिबिटर एंड डायबिटिक, दिस इज द आइडियल. लेकिन एक पेशेंट को हार्ट डिजीज है, उनमें जनरली बीटा ब्लॉकर्स हेल्प करते हैं, स्ट्रोक में नहीं करते. अगर आप दो चीज़ें हैं, एक कंट्रोलिंग ब्लड प्रेशर, रिड्यूसिंग द रिस्क। एक जो ड्रग आपकी यूज़ कर रही हैं वो अबव कंट्रोल ऑफ ब्लड प्रेशर, उसकी अपनी एफिकेसी है टू रिड्यूस द स्ट्रोक रिस्क। अब स्ट्रोक के लिए एज ए न्यूरोलॉजिस्ट अगर किसी को TIE है, एथेरोस्क्लेरोटिक डिजीज, माई ड्रग ऑफ चॉइस भी नंबर 1 भी ACE/ARB इनहिबिटर, कैल्शियम एंटागोनिस्ट, और अगर आइसोलेटेड हाइपरटेंशन का ज़्यादा कम्बिनेशन विद डायबिटीज, दैट इज़ द कम्बिनेशन विच आई यूज एज ए स्ट्रोक प्रिवेंशन। ज़ाहिर है कार्डियोलॉजिस्ट के हम देखते हैं अक्सर मरीजों में दे हैव टू यूज बीटा ब्लॉकर, तो ये उनकी है। डायबिटिक पेशेंट में अगेन ड्रग ऑफ चॉइस आर ACE एंड ARB इनहिबिटर्स, क्योंकि वो उसमें आपका प्रोटीन यूरिया को भी कंट्रोल करे। तो यू हैव टू सी कि what are the associated risk factor with the patient and age of the patient. Elderly isolated systolic hypertension, diabetics are produced vascularly.
So we have not mentioned anything about smoking.
No, देखिए स्मोकिंग ये तो है ना जो प्राइमरी रिस्क फैक्टर्स हैं, उसमें स्मोकिंग है, ओबेसिटी है, ये डाइटरी फैक्टर जो आपने कहा कि वो तो डेफिनेटली है। लेकिन जो पर्टिकुलरली डाइटरी हैबिट्स हैं, जैसे एक स्टडी हुई थी, सिर्फ सॉल्ट रिस्ट्रिक्शन को आप कम कर दें तो योर ब्लड सिस्टोलिक एंड डायस्टोलिक ब्लड प्रेशर विल रिड्यूस बाय 5 मिलीमीटर, यानी ओनली रिस्ट्रिक्टिंग द सोडियम इनटेक। तो वो चीज़ें करें। बाकी स्मोकिंग ठीक है कि सेपरेट इंडिपेंडेंट रिस्क फैक्टर्स है, उसको हम करते हैं। बाकी एक बड़ा अच्छा सवाल किया था डायज़ेपिम और ये बेंजोडाइज़ेपिन पे। ये तो मुझे भी गिला है कि हमारे बहुत सारे कार्डियोलॉजी कोलीग जो है ना, और मतलब है कि दे ऑलवेज कीप पेशेंट ऑन स्मॉल डोज ऑफ बेंजोडाइज़ेपिन। मेरे पास जब डिमेंशिया से आते हैं ना, तो वो उनकी डोज जो उन्होंने 0.25 मिलीग्राम शुरू होती है, वो उस वक्त तक 3 या 4 टैबलेट में है, और डिमेंशिया गेट वर्स। तो मेरा यही मैसेज है कि एक्यूट कॉर्नरी सिंड्रोम है, कोई MI हुआ है, ठीक है, लेकिन उसको बंद भी कर दें, देते ही ना रहे हफ्ता 2 हफ्ता। ये बड़ा मुझे रोज़ प्रॉब्लम आता है। डिमेंशिया हो गया, बेंजोडाइज़ेपिन, और स्टडी है कि डिमेंशिया की कंट्रीब्यूटिंग फैक्टर में बेंजोडाइज़ेपिन नंबर 1 प्लस कंट्रोलिंग फैक्टर।
Sir, one thing, you have mentioned that combination is a better option. But if patient has got psychological effect of split drugs, then why we should not prefer to give him split?
नहीं, मैंने तो आपको एविडेंस दे दिया ना कि इफ़ यू आस्क पेशेंट टेक 3 टैबलेट, ठीक है, ये स्टडी है, ये WHO ने भी इंडोर्स किया है। उसकी कंप्लाइंस कितना है? 3 मंथ के बाद कंप्लाइंस इज 65%, 1 साल के बाद कंप्लाइंस इज 50%। ये एविडेंस बेस्ड पर हम बात कर रहे हैं। अब आप ये बताएं, अगर वो बंदा कसम खाता है मैं ले लूँगा, मुझे क्या खराब है? वो बंदा कंप्लाइंस पे शुरू करे ना। वाई वी आर गोइंग, आप खुद देखें, आपने एंटीबायोटिक लेनी हो, अगर 1 मोनोथेरेपी आप ले लें, आप एज ए डॉक्टर हम भी देख लें, वी आर ऑल बिजी पीपल, और आजकल के दौर में तो रुपया कमाना सबसे मुश्किल काम है, ठीक है, इतनी महंगाई है, तो लोगों को रिलीफ। अब एंटी एपिलेप्टिक है ना, आई प्रेफर कि 1 or 2 डेली डोज हो, नॉट 3 टाइम। तो अगर एक मरीज़ लेने को तैयार है, फारिग है, वेल एंड गुड,